Fundamentals of truncal regional analgesia. This is Dr. Terkawi. I'm currently an assistant professor at the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University. First, I would like to thank my colleague Dr. Hisham Sharkawi for providing me with a lot of the materials, including some videos that you will see in these lectures. I also would like to thank him for being a pioneer in the field of interfascial plain block. As you will see, he wrote many of the papers that we'll be discussing. So the way I designed this lecture or series of lectures, this will be a long lecture, so bear with me, but I will walk you through the anatomy so you understand why and how we are doing all these blocks. For technical details to how to do each of these blocks, there is a video for each one. So if you want a quick video, you want to know how to do erector spinae plain block, for example, please go and watch that video. But I recommend you watch this video first so you understand the concept behind all these blocks. So let's get started. First, we'll talk about muscles. And specifically, we start with the anterior thoracic wall muscle. So this is a busy table I added here so you can take a screenshot, save it. It summarizes all the important muscles in the anterior thoracic wall. And let's go through them. So this picture, so the way this next few slides working, I am going from superficial to deep. I'm taking the muscles layer by layer to show you how they attach to each other. So from the above, although it's not relevant to the anterior thoracic wall, the trapezius muscle, then the platysma, very thin muscle. What's more relevant here is the pectoralis major muscle. So the pectoralis major muscle, it originates from the medial half of the clavicle here, and the anterior surface of the sternum, and first 7 costal cartilage aponeurosis. So 7 costal cartilage aponeurosis, and it inserts to the lateral lip of the intertubercular sulcus of the humerus around here. I'll show you another picture. So this muscle is mainly innervated by the lateral pectoral nerve. Some innervation from the medial, but mainly from the lateral. And the function of this muscle is for adduction, medial rotation, and flexion of the humerus at the shoulder joint. So I took the first layer. Here you will see the sternocleidomastoid under the platysma, and more relevant, the pectoralis minor muscle. So for the pectoralis minor, it originates from the anterior surface of the third, the fourth, and the fifth ribs, and deep fascia overlying related intercostal spaces, and it inserts in the coracoid process of the scapula. It is innervated by the medial pectoral nerve, and its function to depress tip of shoulder and protracts scapula. Down there we have the external abdominal oblique muscle, which I will cover it when we talk about the abdominal wall muscle, but it's in the same fascial plane. Underneath that, we have the serratus anterior muscle. So the serratus anterior, it originates from the top lateral surface of the first 8 or 9 upper ribs. So if you imagine here, that's rib 1, number 1, 2, 3, 4, 5, 6, 7, and 8. And then it goes posterior and medial around the rib cage, pass underneath the scapula, and then it inserts on the underside of the scapula on its medial border. As the muscle extends from the ribs, it is divided by tendons, septa, into 9 finger-like groups. We call this digitations. So these are the digitations. This important muscle is supplied by the long thoracic nerve, which originates from C5 to C7. The function of the serratus anterior muscle is to do protraction and upward rotation of the scapulothoracic junction. Next to that, you have the external intercostal muscle, which is muscles between the ribs that originate from the inferior margin of the rib above the superior margin of the rib below, and it's supplied by the intercostal nerve. And these muscles are mostly active during inspiration, and it support inspiration effort. When we go medial toward the sternum, this muscle become a membrane. And then we have the rectus abdominis muscle here in the same plane. So this is a magnified picture for the intercostal muscles. So you have the external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. You see the difference between the the origin and insertion here, and what's between the internal and inner most intercostal muscle is the vascular and nerve bundle. Now, this is another cut. This is an axial cut looking from above and around T1 level. It shows you here the head of the humerus and the scapula here, and this is probably the first or the second rib. And then, as you see here, the pectoralis major and the pectoralis minor here. So just give you an imagination that explain. We will see in the PICS block when you put the ultrasound here more medial versus here more lateral, how you find the pectoralis minor, and underneath that you have the serratus anterior attached to the thoracic wall. Now let's talk about the posterior and lateral thoracic wall muscles. Again, this is a summary table. It's a busy table, but I will dissect this table. This is for you if you need to save it. So this time I will build these layers from deep to superficial. So let's get started. So here on the right side, the first muscle ever, we have the multifidus muscle. It's important to know that this muscle goes from sacrum all the way to the cervical. Then above that, we have the erector spinae muscle. It is very important to understand that the erector spinae muscle is basically it's a group of 3 muscles. Spinalis, which is more medial, then next to it the longissimus, and then the iliocostalis. So the way this anatomy goes, that the same name, if you are in the neck, so it will be capitis, so spinalis capitis. If you are in the thorax, so it will be spinalis thoracis. If you are in the lumbar region, it will be spinalis lumborum, iliocostalis lumborum, and etc. And as when it goes close to the sacrum, the erector spinae muscle become aponeurosis. Now, this is another picture, the same thing. The reason why I added this because I want to show you the fibers of the multifidus muscle, right? Here it's not very clear, but it's important because when you look at it under ultrasound. And this is a big picture. We'll go over all these muscles again and again. Above that, we have a bunch of muscles, but let's start from the top. This is again the same plane. So we have spinous capitis muscle, splenius capitis muscle, splenius colli muscle, and levator scapulae muscle, supraspinatus and infraspinatus, that's the rotator cuff muscle. And what's more relevant here, the serratus posterior superior muscle, which originate from the knuckle ligament spinous process of C7 to T3, C7 to T3, and it insert in the second to fourth ribs near their angles. So this muscle is innervated by the second to fifth intercostal nerve, and the function of this muscle is to elevate ribs. Then here we have the erector spinae muscle again, and this is the serratus anterior, but again, more relevant here is in this fascial plane is the serratus posterior inferior muscle. This is not very popular muscle because we don't, it's not a landmark for interfascial plane block like the superior posterior superior muscle. But this muscle, the superior posterior inferior, it originates from the spinous processes of T11 to L2. And it inserts in the inferior border of the 8th to 12th ribs near their angle. This muscle is innervated by the 9th to 11th intercostal nerve, subcostal, and it works as a depress. It depresses the ribs, the opposite of elevate the ribs of the superior posterior, serratus posterior superior. And here we see part of the internal abdominal oblique muscle. Now, adding another layer here, this is even more relevant for regional blocks and interfascial plane blocks, the rhomboid major and minor. So the rhomboid minor, it originates from the inferior part of the knuckle ligament and spinous processes of C7 and T1. And then the major, the rhomboid major, it originates from T2 to T5. So if you're talking about both rhomboid muscles, they originate from C7 to T5. And these muscles insert in the medial border of the scapula from the level of the spine to inferior edge, from here to here. And it is supplied by the dorsal-scapular nerve, which come from the C4 and C5. And the function of the rhomboid muscle is to retract the scapula and rotate it to depress glenoid cavity and fix the scapula to the thoracic wall. If you go below, you will find the latissimus dorsi muscle. So the latissimus dorsi muscle, it originates from the spinous processes of the inferior 6 thoracic vertebrae. So from almost T7 all the way down to T12, and it also originates from thoraco-lumbar fascia, iliac crest, and inferior 3 or 4 ribs. It's really a big muscle. Now, it inserts in the intertubercular sulcus of the humerus, which is the bicipital groove. So it goes all the way almost there. The latissimus dorsi is innervated by thoracodorsal nerve, which originate from C6, 7, and 8. And the function of the latissimus dorsi is to extend, adduct, and medially rotate the shoulder. It also elevates body toward arms during climbing. Then above that, the most superficial muscle is the trapezius muscle. So as you see, the trapezius also another big and thin muscle in the upper back. So it originates from the medial third of the superior knuckle line, external occipital protuberance, knuckle ligament, and spinous processes of C7 to T12. So it goes from the occipit all the way to T12. And then it attach laterally to the lateral third of the clavicle, acromion, and spine of the scapula. This important muscle is supplied by cranial nerve 11, or the spinal accessory. The function of this muscle is to elevate, retract, and rotate the scapula. Descending part elevate transverse part and retract, and ascending part depress scapula. Descending and ascending part both act together in the superior rotation of the scapula. So basically, rotate the scapula, elevate, and retract. When we have injury to the cranial nerve 11, the spinal accessory, so we have paralyzed trapezius, we get the classic picture that we remember from medical school of the winging scapula. Now, this is another picture to put them together. We already learned about them, but this is a bigger picture. They are together. And this is another picture looking from the side, show you the serratus anterior, pectoralis major, latissimus dorsi, and then how the external oblique, I'll talk about that, and just give you an overview how these muscles become all together. Now, this is another way of looking at this muscle, another summary picture. So from looking from superficial to deep, so trapezius muscle here, rhomboid muscle here, and inferior infra spinatus muscle here, latissimus dorsi here, iliocostalis muscle, and this is the serratus posterior inferior. Then as we go deeper, we get the erector spinae muscle and the multifidus muscle at the end, which is from here all the way above. Now, let's talk about muscles of the abdominal wall. So this is again same thing. This is a table that summarizes these muscles. You are welcome to save this table and we'll go over these muscles. So let's talk about the first muscle. Again, I'm starting from deep to superficial now. So the first muscle is the transversus abdominis, which originate from the 7th to the 12th 7th to 12th costal cartilage, and also it originates from the thoracolumbar fascia. It also originates from the iliac crest, anterior superior iliac spine, and iliopsoas fossa, inferiorly obviously, and it travel medially and insert in the linea alba and the pubic crest. The transverse abdominis muscle is innervated by intercostal nerves T7 to T11, as well as some subcostal nerve from T12, and also by the iliohypogastric and ilioinguinal nerve. The function of the transverse abdominis is to rotate the trunk to the same side. And when both muscles in both sides contract, they help to compress the abdomen during bowel movement, for example. Above that, you have the internal abdominal oblique muscle, which originate from the, again, thoracolumbar fascia, um, and it goes all the way and insert in the 10th to 12th reps. So from here 10, 11, 12, and it is innervated also by the same innervation of the transversus abdominis, which is intercostal nerve T7 to T11, and subcostal nerve branch from the T12, as well as iliohypogastric and ilioinguinal. And its function, it helps to stabilize the pelvis and also flex the trunk. Then above that, the most superficial muscle and the largest muscle among them is the external abdominal oblique muscle, which originate way higher from the 5th to the 12th rib, outer cervix, and it go medial and insert in the linea alba, pubic tubercle, anterior iliac crest. The innervation of this muscle from intercostal nerve, again T7 to T11. So most of the innervation of all these muscles, the external oblique, the internal oblique, the transversus abdominis, come from intercostal nerve T7 to T11. And this is important to keep in mind, especially if you are doing intercostal nerve block or burning the intercostal nerve block. If you do more than 3 level from T7 and below, you are paralyzing these muscles. So most likely the patient will not have these muscles to help him or her to breathe. And it's a common that the patient will come to you and complain of shortness of breath if you go more aggressive and burn more than 3 intercostal nerves between T7 and T11. So the function of the external oblique is to flex the trunk to the same side and also rotate the trunk to the opposite side. Now, this is a picture just to show you how they merge together to form the aponeurosis that continue and then attach to linea alba, goes above and below, as you see here, the rectus abdominis muscle. And this is also important landmark when you want to do the tab block, which we'll have in a separate video. Now, underneath that, we have two important muscles. One is the quadratus lumborum muscle. So the quadratus lumborum, as you see here, it originates from the iliac crest and iliolumbar ligament, and it inserts in the number 12 rib, as you see here, and L1 to L4. So 12th rib, and L1, 2, 3, and 4. This muscle is supplied by the subcostal nerve from T12 and from L1 to L4 spinal nerves. The function of this muscle, if it contracts unilaterally, is to flex the trunk to the same side. Bilateral, it helps in bearing down, again during bowel movement, and expiration stabilizers because it's attached to the 12th rib. And this is very common, also important muscle when you have a myofascial pain in your back, and commonly gets strained, this muscle, especially with twisting and flexing movement to the same side. The second important muscle is the psoas major muscle. The psoas major muscle, it has superficial and deep layer. It originates from T12 to L4, very similar as you see here to quadratus lumborum. But the difference from quadratus lumborum that this goes way down here, and it inserts to the femur, specifically to the lesser trochanter, and joint insertion as iliopsoas muscle. This psoas muscle is innervated from L1 to L2, sometimes L3 spinal nerve. The psoas major muscle is important for hip joint. So it helps flexion and external rotation, lumbar spine. And when it contracts unilaterally, it flexes trunk laterally. If it contracts bilaterally, it raises trunk from supine position. So it's a very important muscle for the movement from sitting to standing and for flexing and external rotation of the hip. In some people, about again, this is the quadratus lumborum. Underneath that, you have the psoas major and minor. The psoas minor is not a very important muscle for our blocks. Also, but what's important to know, it's not always present. Only about 50% of population they have psoas minor muscle. And then here you have the iliacus muscle. This is another picture here with what's important to remember, especially for the external oblique, that it starts from 5th rib. This is important when we gonna talk about the external oblique intercostal nerve or plane block, sorry. And then when you go lower than that, the internal oblique, it's from 10th rib, and similar to that, the transversus abdominis from the T7 usually, so in between these two muscles. So in the thoracic wall, there are not 3 layers all the way as we see them when we put the ultrasound probe in the abdominal wall. This is an axial cut just to briefly show you. This is all the erector spinae muscle. It has the multifidus underneath it, although it's not part of the erector spinae. Then these are the erector spinae muscle. Then here you have the QL, quadratus lumborum, and here the psoas muscle. Now let's talk about thoracic wall vessel, some important thoracic wall vessel. There are few vessels that I would like you to be aware of. The first one is the axillary, which is continuation of the subclavian artery, and it runs with the axillary vein, It's an important landmark, and it gives the following branches. So first we have the superior thoracic branch, which is the first part of the axillary artery. It supplies both pectoralis muscle. And then we have the thoracoacromial branch, which has pectoral and clavicular sub-branches. It arises from the second part of the axillary artery, deep to the pectoralis minor, and close to the upper border of the pectoralis minor. It pierces the the clavipectoral fascia in the infraclavicular fossa. So it's an important landmark when we are doing PICS block, and also when we are doing clavipectoral fascia plane block. Then after that you have the lateral thoracic. Follow the lower border of the pectoralis minor, supplies both pectoralis muscle. Then just lateral to that you have the thoracodorsal, which arise from the third part distal to the pectoralis minor of the axillary artery. So the way when we say first part, second part, and third part, it's all relation to the pectoralis minor. So distal to pectoralis minor is the third part. And this important nerve, artery, it runs with the thoracodorsal nerve. And then finally, we have the internal thoracic or mammillary artery, which arises directly from the first part of the subclavian artery. It supplies structure of the thoracic and abdominal wall, thymus, sternum, and skin. And again, it's a very important landmark when we are doing parasternal block, especially the deep one. Innervation. So this is a very important picture. If you understand this, you will understand all the truncal blocks. I will leave this for you, and I will start building this picture with you. But this is an important picture to save somewhere. Now, let's see how this works. First, it's important to know that this is only from T2 to T12. So first, from the spinal cord, we have ventral or anterior root and dorsal or posterior root. They merge together to form the spinal nerve. With the dorsal root, we have a small bulge here. It's a ganglion called the dorsal root ganglion, or sensory spinal ganglion. And here we have the sympathetic ganglion. And then the ventral root transmits efferent motor neuron and preganglionic autonomic neuron. The preganglionic autonomic neuron synapse with the postganglionic autonomic neuron in the sympathetic ganglion here. The sympathetic ganglia are connected to the spinal nerve, as we see here, with the gray and white rami communicates. The dorsal root transmits sensory afferent neuron from the viscera, the somatic tissue, and their cell body are connected in the dorsal root ganglion located at the intervertebral foramen. As you see, it's in the foramen. And then they give the spinal nerve, which in adult, as you see this small part here, is about 2 centimeters. So From now, everything is mixed together. So from now, everything is mixed together. So motor, sensory, and autonomic, they are together. So the spinal nerve now give you two branches. The ventral rami, notice now we are calling it rami, not root. The ventral rami, which continue as intercostal nerve, and the dorsal rami posteriorly. The ventral rami innervate the anterior and lateral wall of the torso, as well as the intrathoracic and intra-abdominal organs, while the dorsal rami innervate the intrinsic muscle of the back and cutaneous tissue of the posterior torso. Each dorsal ramus branch of the spinal nerve turn posterior, as we see here, into medial and lateral branches. Some references also add intermediate branch. The lateral branch here, and then the medial branch also bifurcate to give you the posterior cutaneous branch. In the thoracic spine, this division occurs at the dorsal ramus, pierce the posterior boundary of the paravertebral space. The medial branch innervate the transversospinalis group of the muscle. Mainly, we are talking about the multifidus muscle here, and the facet joints. While the lateral branches mostly supply the erector spinae muscle. The longissimus, remember, and intercostalis, these are the erector spinae muscles. Then each ventral ramus is continuing with its respective intercostal nerve, which run forward in the intercostal space. Numerous branches arise from each intercostal nerve along its course to supply the various muscle and connective tissue that constitute the lateral and anterior thoraco-abdominal wall. So the intercostal nerve give you two main branches, the lateral cutaneous branch and the anterior cutaneous branch. The lateral cutaneous branch further divide into anterior and posterior, and it's important to know that the intercostal nerve run together with the intercostal artery and vein, which is an important landmark. So what is also important to know where these branches happen. So about mid-axillary line, the lateral cutaneous branch start to branch off to the anterior and posterior branches that innervate the skin anterolateral. Usually this is the lateral cutaneous here pierce through the serratus anterior, and in the plane above the serratus anterior, it bifurcates to the anterior and posterior branches. This picture specifically shows you that it is between the pix muscle and the serratus anterior muscle, but other references, which I tend to believe that it pierces through the serratus anterior. But the whole point that if you go above the serratus anterior or above the pectoralis major, so if you go above pectoralis major here, you will only catch the anterior branch. If you go above serratus anterior here, you will only catch posterior branch. If you go underneath the serratus muscle here, then you will catch the lateral cutaneous branch, which hopefully will cover the anterior and posterior branches. More to come in the next lectures. Then the anterior cutaneous branch except at T1, there is no anterior cutaneous branch. It bifurcates further to medial and lateral branches. Again, this bifurcation, it's important to know where they are happening. So the bifurcation, as you see here, it's between the pectoralis major and the internal intercostal muscle. So this is the transversus thoracis, and this is the internal intercostal muscle here. It goes and above the pectoralis major, it branches to lateral and medial. So as long as you are under the pectoralis major, then you should get the anterior cutaneous branch. And in the parasternal block lecture, I will revisit this concept. Now, another important thing to know that there is overlapping midline innervation from contralateral intercostal nerve, which is anatomical variation, and there is intersegmental connection between adjacent intercostal nerve, also common, and this explain the variability and overlap that we see in the dermatome pictures. This illustration put it all together with the muscles, so it's another important slide to save. As I said, there is some controversy where the lateral branch bifurcate to anterior and posterior, but most of the references, at least in the regional analgesia and anesthesia, it goes through the serratus anterior, but it's important to understand that difference in the interfacial plane and how this will be implicated on different blocks. Now, this is another view. What I like about this picture, which I want you to understand, that these intercostal nerves, they travel downward and of course forward, but why is that? Because they follow the rib, right? And this is an important concept. It's an important concept. And sometimes you look here and said, oh, I'm putting the block here, am I gonna cover the abdomen? If you keep this in mind, this is very important concept to when you are doing these blocks. So don't look horizontal and say, okay, I'm blocking here, I'm gonna block here. No, or I need T10, so I go straight and go lumbar. So T10 is like literally here. And all these muscles, all these nerves, another important example here, the iliohypogastric and ilioinguinal nerve, they come from the lumbar here, which I will cover, they wrap around and they go inferior. This is another important picture. So these are terminal nerves, cutaneous branches. These are in the midline. These are the anterior cutaneous branches. These are outer, the lateral cutaneous branches. So if you think about the chest is mostly from T2 up to T5, maybe T6, but the abdomen is mostly from T6 all the way down to T12, and this is an ABA exam, by the way, question. And you see the other nerves, which is also relevant. Here we get some innervation, and this is important, more important for the breast surgery, which I will cover in a minute. So this is another important picture to look at these colors. So this light green color indicate the innervation with the anterior cutaneous branches. This is supraclavicular nerve, and these are the medial cutaneous branches and lateral also. This is mostly lateral. So this is important to keep in mind. So I'll give you an example. If we have a chest tube here and the patient is complaining of pain, but mostly in the chest tube side, and you want to cover that. These are lateral cutaneous branches. So you cannot go and do pectoralis major or PICS block and expect this to be covered. This is mostly like a serratus anterior plain block, and whether superficial or deep, that we will see in that lecture. But you get the concept. This is very important dermatomal innervation picture for the chest wall. This is the dermatomes. So again, if you want to cover the breast surgery, really from T2 to T5, abdomen will be from T6 to T12. Okay, let's talk about some important thoracic wall nerves. Again, this is a summary table just for your reference. But here, what I would like you to focus on few nerves. The first one I would like to start with is the long thoracic nerve, the LT. So LT, 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 long thoracic. So the long thoracic, it originates from the roots of the brachial plexus, specifically C5, 6, and 7. When it course, it descends posterior to C8 and T1 rami and passes distal and external surface of the serratus anterior. So as you see, it goes lateral and in the lateral wall, and then mostly it's a lateral wall muscle. And if you remember, it's supply or innervate the serratus anterior muscle. Then the next important muscle is the lateral pectoral nerve. So the lateral pectoral nerve, which is this one here, it originates from the lateral cord of the brachial plexus. Specifically here, we're talking about C5, 6, 7. It pierces the clavipectoral fascia to reach deep surface of the pectoral muscle, as you see here. It innervates the pectoralis major mostly and slightly the pectoralis minor. It penetrates the claviculo-pectoral fascia to supply the pectoralis major directly and through communication with the medial pectoral nerve, the pectoralis minor. There is no cutaneous branches. It can be located on the deep surface of the pectoralis major. Then the next muscle nerve is the medial pectoral nerve. So the medial pectoral nerve is originated from medial cord, specifically C8 and T1, and it penetrates the deep surface of the pectoralis minor to innervate the muscle, specifically the pectoralis minor. And then we have the thoracodorsal nerve. The thoracodorsal nerve here is a nerve that also runs in the lateral thoracic wall. It originates from the posterior cord, specifically C6, 7, and 8. And it's a large nerve, and it courses in the posterior axillary wall across the lower border of the teres major to enter the deep surface of the latissimus dorsi muscle. The thoracodorsal nerve is an adjacent to the thoracodorsal artery, so it's an important landmark, and it innervates the latissimus dorsi muscle. The last nerve I would like you to pay attention for is the dorsal scapular nerve. So the dorsal scapular nerve, as you see, it also originates from the brachial plexus, specifically from the anterior ramus of the C5 with frequent contribution from C4. So all these nerves, as you see, they leave between the middle scalene and anterior scalene muscle, but it depends where they go. So the long thoracic go to and thoracodorsal in the lateral wall, the lateral pectoral, medial pectoral in the anterior wall, and the dorsoscapular in the posterior wall. So the dorsoscapular pierce scalenes medius, descend on the deep surface of rhomboid, and it supply the rhomboid and occasionally supply levator scalene. This is another picture here to show you the lateral pectoral nerve, lateral pectoral nerve here, medial pectoral nerve here, and how they are very close to the thoracoacromial artery, which is an important landmark when we are doing PICS block. We'll cover that. This is another picture. We are doing a cut through the axilla here. So you see the lateral and medial pectoral nerve, and they are originating from the brachial plexus. As I said, the lateral pectoral from C5, 6, C5, 6, and 7. And that's the lateral cord specifically, and how they bifurcate and how they also run with the artery. This is another picture mainly to show you the course of the long thoracic nerve. It's right there. And the intercostobrachialis nerve, and these are the serratus anterior here and latissimus dorsi. So when we are doing a breast surgery, or we have a breast pain, or we have anterior abdominal wall pain, it's very important to keep in mind this picture, and I would also save this picture. So most of the innervation, as I said, from T2 to T6, you may get some innervation from the supraclavicular nerve. These are the supraclavicular nerve, which originate from brachial plexus, mostly C4. But as you see here, you have lateral and medial pectoral nerve. You have the anterior cutaneous branches here. You have the lateral cutaneous branches. And if your patient have an axillary dissection, then you also want to think about covering the intercostobrachial nerve and long thoracic nerve, and to less extent thoracodorsal nerve. And we will cover that when we talk about blocks. Another similar picture, very similar to the previous one. And let's wrap up with visceral innervation here. So this is abdominal visceral innervation, which is also important to keep in mind when you are treating pain. So cell bodies of the sympathetic neuron in green are located in the anterior lateral horn of T1 to L2 spinal cord segments. Efferent fibers, or cholinergic, pass by way of the ventral root to a white ramus communicanus, and then to the paravertebral sympathetic ganglia. They continue via a splanchnic nerve to prevertebral ganglia, for example, the celiac ganglia, and from here you get multiple branches for autonomic plexus. Then you have the adrenergic vasomotor, which is efferent, also leave the sympathetic ganglia to innervate blood vessels. You have sensory afferent neuron from the viscera, represented by the blue line here. It travels in the reverse direction along the same pathway as sympathetic efferent neurons, but are functionally separate. The visceral sensory neurons enter the spinal nerve via white rami communicantus and converge with the somatic sensory neuron. They both project onto second-order neuron in the dorsal horn of the spinal cord, and this viscerosomatic convergence is responsible for the phenomenon of referred pain. Visceral pain sensation may be blocked at the level of the celiac ganglion or plexus, or at the level of the spinal cord, spinal nerve and cord. This is an important concept, especially when we are dealing with the interfacial plane block. However, blocking the later side will also interrupt motor somatosensory function, which is generally undesirable. There are also afferent carried in branches of the vagus nerve. These neuron or pathway not shown, it's not shown in this picture, have their cell body within the superior and inferior ganglia located within the jugular foramen and project to the solitary nucleus in the medulla oblongata. Finally, each spinal nerve and its representative dorsal and ventral ramus contain sensory, motor, and autonomic neuron. All somatic and visceral sensory afferent include nociceptive have their cell bodies within the dorsal root ganglia, and all the axons are contained within the dorsal rootlets that connect the dorsal column of the spinal cord. The sympathetic ganglion is the site of synapses between preganglionic and postganglionic autonomic efferent neuron that are responsible for sympathetically mediated pain. Motor efferent as their own pathway, and the above governs the characteristic of neural block that can be expected from local anesthetic action at the specific site. Now, the last thing I would like to talk about is the fascial planes. Important concept here. So the fascia is fundamentally composed of soft collagen containing loose and dense fiber connective tissue that permeates through the whole body. There are three fundamental fascial connective layers: superficial, the deep, and muscle-related fascial layer. There is four important fascial principles related to the interfacial plane block. One, the continuity of the fascial system. Mediolateral and craniocaudal, unlike peripheral nerve or plexus, interfacial plane block may have multiple potential points of injection, and various names has been assigned to block in the same tissue plane, although between different muscle layers. Biomechanical properties of fascial tissue: 30% of muscle tendon insert in fascial planes. Every time a muscle contracts, fascia also do. Theory of this explains the theory of migratory local anesthetic or dynamic fascia mobile, like bumping action to move the local anesthetic. 3, rule of local innervation. Nerve elements inside fasciae itself, not the nerves that pass through these layers, could be one of the mechanism of action of fascial block in addition to the transfer of medication to peripheral nerves. Finally, regional fascial specialization. Different fascial plane differ in structure, membrane, and relationship with surrounding organs. Lumbar, talking about thoracolumbar fascia, is the more mobile than thorax. Middle thoracolumbar fascia is 3-layer in some area and 5 in other area. There are 2 key fascia in the neck. So in the neck, we have superficial cervical fascia and deep cervical fascia, which has 3 layers. The investing, which is the superficial, the pretracheal, which is the middle, and prevertebral, which is deep. The prevertebral fascia form the tubular compartment and that contain a lot of muscles and innervation, as you see here. So you have superficial cervical fascia, and then underneath that you have the deep cervical fascia, which give you 3 layers. The investing, which is the most superficial here, and underneath that the pretracheal here, and the deepest is the prevertebral layer. This is important when we are doing interfascial plane block, especially the erector spinae, which we'll cover in its lecture. When it comes to the abdomen, we have the thoracolumbar fascia, which anchors the abdominal wall and paraspinal muscle to the spine, provide core stability. It has it is divided into anterior, middle, and posterior thoracolumbar fascia, which are important landmark and concept when we are doing specifically quadratus lumborum block. So, for example, here, that's the posterior, that's the middle, and this is the anterior. So, if you are doing anterior quadratus lumborum, then you will put your medication here. If you are doing posterior quadratus lumborum, you are get posterior to the quadratus lumborum in the level of the middle thoracolumbar fascia, and the lateral, which is type 1 QL block, is right here, which also will be covered in a separate video. So the abdominal fascia or thoracoabdominal fascia, there used to be 2 model concept or either 3 model, which we discussed, means anterior, middle, and posterior thoracolumbar fascia, or the 2-layer model. The 3 is more commonly used. So why we learned all of that? Because now we can do literally almost 20 block just by understanding what we learn from muscle and innervation. So here we can do rectus sheath block, which is injection between rectus abdominis muscle and posterior rectus block. Here we do the ilioinguinal and iliohypogastric nerve, and then here we do transverse or tab block. This is Here we do it at the mid-axillary tab block. This is subcostal tab block. And this is here anterior quadratus lumborum block, which is between the QL and psoas muscle. And here we have the lateral quadratus lumborum block, which is between the aponeurosis of internal oblique and transversus abdominis at the lateral border of the QL block. And also we can do it here, posterior QL block, which is between the QL and erector spinae block. If we go more lateral here, we can do transversalis fascia plane block, which is between transversus abdominis and transversalis fascia. And we keep going to here, number 10, is the rhomboid intercostal plane block, which is between rhomboid major and intercostal block. We go to 11, it's paravertebral block in the paravertebral space. And then we go to 12 here, it's the intertransverse process block, which is between two transverse processes posterior to the superior costo-transverse ligament. 13 here, where you do the erector spinae plane block between the erector spinae and transversus process. 14, here you can do retrolaminar block between erector spinae and the lamina. And then 15 is the superficial serratus anterior block, which is superficial to the serratus anterior muscle. And 16 is the deep serratus anterior plane block, which is posterior surface of the serratus anterior muscle, and with the periosteum of the rib. And then 17 here is the superficial parasternal intercostal plane block between pectoralis major and internal intercostal muscle. Then here you can do the deep PIP, the parasternal intercostal plane block, and 19 interpectoral plane block, which is basically PIX1, and 20 is a pectoroserratus plane block, which is basically PIX2. So we will learn about all these blocks in separate videos. And this is just for your reference. Thank you for watching, and we'll see you in the next videos.